I'm sorry I lost connectivity. Today we have the honor of hearing Alaka ma'am on diagnosis of tuberculosis. This is by request from a lot of participants, and tuberculosis has become a big challenge now. So what are the newer things for tips? Ma'am, some questions have come which I have sent you on WhatsApp. So after you finish, if you have time, you can please look at them and answer them. Please continue. Welcome and please start.
Okay. Good afternoon, everybody. So today I'm going to talk to you about diagnosis of tuberculosis. Tuberculosis is our age-old friend. You know, the first evidence of tuberculosis, mycobacteria have said to be on the earth for 6 to 7 millions of years. But the first evidence that we saw was 3,700 years before Christ in our Egyptian mummy. She had a TB spine. That means TB is known since then, 3,700 plus these 2023, so more than 5,500 years. Hippocrates has written about tuberculosis. Sushruta has written, in Sanskrit it is called as Raja Yakshma. In the recent times, I'm just giving you a little history. It was Fracastro who described the contagious nature of tuberculosis. Sylvius, while he was doing an autopsy, he found a small peripheral lesion, which was white in color, solid. He called it as tubercle. Probably that was a Ghone's lesion, but he called it as tubercle. And since then, we call it as tuberculosis. Louis Pasteur in 1862 said that it is airborne. Wilhelmine said it is transmissible through air. Robert Koch, we all know, in 1882, described Mycobacterium tuberculosis. Ehrlich in 1885 showed that it is acid-fast bacillus. And Röntgen in 1895 discovered X-rays, and that made our job easier. Did it make our job easier or more challenging? We'll have to see. Tuberculosis in India is #1 infectious disease. And now the number is increasing. We failed to control it over last so many decades, but now the number is rising because of many other conditions, particularly HIV, which has spread like anything. Every fourth Indian is now suffering from diabetes. So diabetes itself predisposes to the chronic tubercular infection. Long-term steroid therapy, patients who are on steroid therapy, they are immune compromised. Diabetes is immune compromised state. These are the people who are developing tuberculosis, and people who are using immunosuppressant drugs. Nowadays, for many conditions, we use these drugs. Like for rheumatoid arthritis, we give methotrexate for a long time. There are many other conditions, chemotherapy, and so on. So, therefore, the number of tuberculosis infections in India is increasing. So, how do we diagnose it? The diagnosis of any medical condition is first made clinically. Then, because it is an infectious disease, we have to give bacteriological evidence, radiological evidence, and need be, then we do the imaging. So what are the systemic manifestations? This is a chronic infection, and therefore this infection will give rise to systemic manifestations like evening rise of temperature. It is a low-grade fever which occurs in the evening. When I was a student, Dr. O.P. Kapoor had told us that patient comes and says, mithi mithi bukhar aati hai. So it is a low grade fever, mithi mithi bukhar. And because he gets it in the evening, during night, the fever comes down and therefore he gets night sweats. This is also accompanied because it is a chronic infection, a loss of appetite. And because there is loss of appetite, there is a rapid loss of weight. I have seen occasionally patients who present with pyrexia of unknown origin. These were two of my residents and few other patients. There was no cause found. We did blood culture, we did all the imaging. For 3 weeks, 4 weeks, there was fever which was going on. And after 3 weeks, one person presented with pleural effusion, other one presented with lymphadenopathy. Therefore, remember, if there is a PO, we have to also wait and watch and look for tuberculosis. Which are the systems which are involved? Now, these are the systemic manifestations that you are seeing here. But in addition to this, there will be manifestations or clinical features pertaining to the system which is involved by tuberculosis. Tuberculosis involves the respiratory system because it is airborne, transmissible. So the first infection is of the lungs. It can cause tuberculous lymph nodes, lymphadenopathy, body cavities, CNS tuberculosis, GI tract tuberculosis, or I don't use the word abdominal tuberculosis because in abdomen we have other organs also. Like we will have renal tuberculosis, intestinal tuberculosis, lymph node, TB peritoneum. So gastrointestinal tract tuberculosis, renal tuberculosis, genital, joints, other organs, eyes. The flictinular conjunctivitis, it's supposed to be because of tuberculosis. It's a hypersensitivity reaction. When we are doing fundoscopy, we can find choroid tubercle. And that is how we always used to suspect miliary tuberculosis, that TB has spread and we see actually the tubercle, a small sago-like thing in the choroid. Bone marrow tuberculosis, and I have seen TB granulomas in the thyroid. So far, I have not come across any report of TB infection of our appendages. If you come across, please let me know. That is nails, hair, and teeth. I have not come across any report TB affecting these appendages. In the respiratory system, in addition to the systemic manifestation, the patient will naturally complain of cough. The cough will be accompanied by mucopurulent expectoration. It will not be mucoid, it will be purulent because there is an infection. And the patient will complain of hemoptysis. You know the pathogenesis of this. When there is a tuberculous infection, this is a hypersensitivity reaction. So the body reacts to this, sends their macrophages, they form Langerhans giant cells, epithelioid granuloma. There is a small patch of pneumonia or a consolidation. I will not say pneumonia, a consolidation. So a consolidation, small patch forms there. And then as per the characteristic of tuberculosis, there is a caseation necrosis, which starts from the center. Now, when there is a caseation necrosis, it liquefies, and that is the sputum which has to come out. So this tuberculosis spreads to the bronchi, erodes the bronchial wall, and then the expectoration comes. So that there is a mucopurulent expectoration. While doing this or while this is happening, there can be erosion of the blood vessel, or there is a blood vessel which is crossing over the cavity that can be stretched and break, and therefore patient will also get hemoptysis. At this time, I must also tell you there is something called as a spurious hemoptysis. Spurious hemoptysis is when the source of the blood is above the vocal cord. The patient comes and tells you that he spit the blood, but that blood might have been coming from the oral cavity. The teeth are bad, the gums are bad, and therefore comes. Or there is a very bad pharyngitis. So there may be a blood stick sputum. So that is called as spurious hemoptysis, while this is a true hemoptysis. Now, when we get the sputum, the age-old method is sputum microscopy. And in sputum microscopy, we prepare a smear of the sputum, and that is stained with a ZN technique. Let me clarify to you here, because the AFBs look red. Some of you might carry the idea that it is a gram-negative bacillus. No, sir, it is gram-positive. Okay, but we stain it. Ehrlich stained it with caramel fission. That gave a red color. And then he poured acid over it. But even with the acid, this red color could not be washed out. And therefore, it is called as acid-fast bacilli. So when we examine the smear, we have to examine at least 100 fields under oil immersion. And in these 100 fields, we see the AFB. You must be getting these reports from the laboratory or even from RNTCP program. They write AFB found scanty, 1+, 2+, and 3+. What does that mean? If they find 1 to 9 acid-fast bacilli in 100 fields, then naturally it is scanty. Very few bacilli. Before that, I must also tell you that to find out these bacilli on the smear examination, it must contain at least 5,000 to 10,000 bacilli per ml in the sputum. Okay, so the bacterial load has to be high. So when we prepare a smear and then we find 1 to 9 AFBs per 100 fields, we call it as scanty. 10 to 99 AFBs per 100 field is called as 1+. 2+ is 1 to 10 acid-fast bacilli in 50 fields, half the fields. And when they are more than 10, seen in 20 fields, we give the report as 3+. So that shows the severity of the disease also. Which are the other bacteria which looks like acid-fast bacilli or Mycobacterium tuberculosis? One is leprosy, another is nocardia. Okay. The second drawback of the sputum microscopy is we cannot differentiate between the dead bacilli and the live bacilli. And therefore, it is necessary that we also carry out further investigations, particularly the culture. So we do the culture and drug sensitivity. Age-old method is using solid media, Lowenstein-Johnson medium. It used to take 6 to 8 weeks for AFB to grow. After these 8 weeks, another 2 weeks for sensitivity test. Okay, that means for about 10 weeks, we don't get the diagnosis and we can't wait for 10 weeks to start the treatment. Then came the liquid media. And this liquid media, the classical example is Mycobacteria growth indicator tube. This has come recently in last 5 to 10 years. Now, what is this Mycobacteria growth indicator tube? Does it grow mycobacteria? So it has a liquid medium in each tube. And in that liquid medium has been added anti-TB drugs. And at the bottom of this each tube, there is a fluorescent material. Now, when we have added anti-TB drugs, and in presence of anti-TB drugs, these bacteria, if they grow, the bacterial growth will be indicated by fluorescence. We require a special instrument to read that fluorescence. But then what it indicates? That the bacteria are growing in presence of anti-TB drugs. That means it indicates drug resistance. Okay. So drug sensitive bacteria can't be grown on this. I mean, they are not seen on this. So drug resistant bacteria are grown on this, and they are indicated by the fluorescent, which is at the bottom of the tube. This also takes about 2 weeks. And therefore, we came to molecular techniques. And this molecular technique, you all are conversant with it, and that is gene expert. Gene expert is a commercial name. This is called as cartridge-based nucleic acid amplification test. So there is a cartridge which is having this reaction which takes place, and it has gene probes. Okay, so this is cartridge-based nucleic acid amplification test. It uses gene probes. The wonderful thing about this is it detects Mycobacterium tuberculosis, even if it is in small quantity. So the sensitivity is very high. And therefore it tells us, yes, this sample has MTB. Okay, which samples we can send to gene expert? Almost all the samples, except urine and blood, that we can't send. Otherwise, you can send CSF, you can send tissues, you can send sputum, anything. We will see that. Okay, so this is gene expert. But what is most important is there are gene probes, and these gene probes detect the mutation in the genes. If there is no mutation for a gene for rifampicin, then the report comes as rifampicin sensitive. But if there is a mutation, then it comes as rifampicin resistant. So within 2 hours, we get the information that yes, this is Mycobacterium tuberculosis, it is rifampicin sensitive, or it is not rifampicin sensitive. What is most important? The turnover time is only 2 hours. So we can instantaneously get the diagnosis. Now, as per our national policy, all TB patients have to be subjected. You counsel them and subject them to HIV test. Because of the drug-drug interaction, the duration of the treatment in presence of HIV, and because tuberculosis is very common opportunistic infection in TB. So all TB cases should be tested for HIV test. Now I come to the age-old, our tuberculosis skin test. It is also called as Mantoux test. Synonymously, it is also called as PPD. What we do? We inject the PPD, purified protein derivative of MTB, that is injected intradermally on the forearm. Remember, if something goes wrong in the technique, if it is not injected intradermally and if it is injected subcutaneously or intramuscularly, we will not get the reaction. So one has to be expert and careful that it has to be injected intradermally. After 48 hours, what we measure is induration, not erythema. So induration is measured. Normal induration is 10 millimeters. It indicates exposure to M. tuberculosis in the past. It's like hypersensitivity reaction that you have injected PPD, which will immediately within 48 hours attract macrophages, Langerhans cells, monocytes, and lymphocytes, and give you an induration. So if the person has received BCG, the Mantoux test will be positive. Positive will be 10 millimeters or 15 millimeters. But as the years go by the age of 18 to 20, the Mantoux may disappear, starts waning. Mantoux is negative in other conditions of immune deficiency, immune compromise, and that is called as energy. In Hodgkin's lymphoma, we don't get MAN2 positive. It is called as energy. Okay. Now, MAN2 test, the positive MAN2 test of 10 to 15 millimeters is not a diagnostic test. Please remember. I have seen a few pediatricians. The mother is concerned that the child doesn't eat. The child is eating absolutely healthy, but she takes to the pediatrician, the child is not eating. So they do the MAN2 test. MAN2 is positive. So they say, see, this is tuberculosis. And then Isonex and some other rifampicin or something given for 2 months. Within 2 months, the child puts on weight, the treatment is stopped. Mother is happy, doctor is happy that he has got his fees, but this is a wrong practice. Because giving these anti-TB for 2 months, we are actually creating drug resistance. Okay. So MAN2 is not diagnostic unless you have a MAN2 which is 30 to 40 millimeters in duration and it is ulcerated. I had my resident who was working in cardiology and she was losing weight. I said, you are losing weight. Is it voluntary or some problem? So she said, no, madam, it is very hard work in cardiology department. So I am losing weight. After a month or 6 weeks, she had a fever for about 3-4 days. Nothing was found. I suggested that why don't you do your MAN2? And MAN2 was 40 millimeter with ulceration. So we started her on the treatment and within about 2 weeks time, the X-ray showed, the lung showed tuberculosis infiltration. Okay. So unless it is 30 to 40 millimeters positive with ulceration, it is not a diagnostic test. It only indicates past exposure to MTB. Then there is a new test which has come that is called as the IGRA, interferon gamma release assay. Okay. Now this IGRA is marketed commercially as quantiferon gold and the other company has marketed it T-spot TB test. It only diagnoses exposure to TB. Interferon is an interleukin, isn't it? So once there is an infection, this will be released and that is measured. But it does not differentiate between LTI, that is latent tuberculosis infection, and the disease. So if it is positive, it only tells you that you have been exposed or you have some TB bacilli in your body. But that all of us Indians are having TB bacilli in our body. We all have latent TB infection. But if our health is good, if there is no opportunity for this bacteria to flourish, we don't develop tuberculosis disease. In India, about 10% of the patients develop tuberculosis over a lifetime. Remaining 90%, they're exposed, but they don't develop TB because of their good immune system. In USA, where TB has been eliminated, they use it to find out newly exposed person. And for that person, they may give Isonex prophylaxis. In our country, now we have decided that we will eliminate TB by 2025. So we have started giving prophylactic treatment to the households or the contacts of a TB infected patient. And therefore, in those patients, we can do this IGRA to find out whether they have contracted a latent TB infection. So we can do it in the contacts of a patient. We can also do it in the healthcare workers, and we can also do it in the travelers. Now I'll show you some cases. This is a 25-year-old MBA student was referred to the gastroenterology clinic for investigations of weight loss. She had no other symptoms. Now weight loss in a young girl would be, first cause will be thyrotoxicosis, but it has many other manifestations, diabetes and tuberculosis. So routine investigations were okay. So X-ray chest was done And as you can see, right upper lobe, so much infiltration with a breakdown, and also in the left mid zone, there is a breakdown. But this is a radiological investigation which needs to be proved by the presence of acid-fast bacilli, because there are many TB mimics which are seen on the X-ray and CT scan, and therefore we need bacteriological investigations to confirm the diagnosis. This is another extensive TB on the left side. On the right side also, you see here there is an infection with a breakdown. This is another cavity. As you can see, multiple cavities here. There is also infiltration in the right upper zone. This was my HIV patient, low-grade fever, cough, expectoration, rapidly increasing swelling. This was a very odd site, therefore I am showing you. This was a cold abscess. His X-ray had cavity with infiltration in the left upper lobe, abdomen, extensive TB, matted bowel loops. Here, although this was a cold abscess, it was not coming from the lymph node or not coming from the rib. It had formed in the skin itself. So he was so immune deficient, as you can see, CD4 was only 128. Then comes the next is lymphadenopathy. Commonly we get cervical lymph node, then axillary, mediastinal, and abdominal. The patient just feels that lymph nodes and comes, says that there is a swelling, but it doesn't bother the patient. There may be systemic symptoms like low-grade fever and all, loss of appetite, but usually that is also wishy-washy. There are no signs of inflammation. So it is not red and tender, so no signs of inflammation. Initially, it is discrete, but later on, it becomes matted. And when they become the lymph nodes coalesce and they get matted, there can be central necrosis. Just 1 minute. Can form cold abscess, and this cold abscess will burst and form a sinus. How do we diagnose? We feel these lymph nodes, then we should do a fine needle aspiration cytology. It's good to be done by an experienced pathologist or an ultrasonologist under an ultrasound guidance. The histopathology will show epithelioid granulomas, Langerhans cells, and lymphocyte infiltration. But sometimes these things are not seen, and the whole clinical picture is of tuberculosis. In those cases, we'll have to do a lymph node biopsy. This biopsy will rule out other lymph node enlargement causes also, like it may be infectious mononucleosis or Hodgkin's or anything. So therefore, if FNAC is inconclusive, please go ahead and do the lymph node biopsy. At the same time, we can do the radiology, X-ray chest, which will show us if there are any mediastinal lymph nodes, USG abdomen for abdominal lymph nodes, and a CT scan. And Dr. Zankaria, I learned it from him. I didn't know till then. This was about 15 years back. He said on CT scan, he was seeing, I had referred a patient to him, that a chain of lymph nodes in the neck, in the mediastinum and the abdomen, and all of them or most of them showed a central necrosis. And central necrosis indicated that this is not malignancy, but this is tuberculosis. So X-ray chest, sonography, and CT scan, as and when required, can be done. I'm just showing you some odd granulomas that I saw. Of course, they were in HIV patient, not normal. This is a bone marrow granuloma. And this is a high power view, which shows you Langerhans giant cells here, and it shows you lymphocytic infiltration. This was a granuloma in the liver. You see this. And the most important is that when we had a smear examination, that also showed direct acid-fast bacilli, which I had never seen in the bone marrow. So this indicated a severe immune deficiency, and therefore there was no body reaction of granuloma, but there were plain simple AFBs. This is actually a TB of the skin, but there are so many lymph nodes which have ruptured and caused this puckering scar. This is called as scrofuloderma. Then I come to the body cavities. In the body cavities, pleura, peritoneum, and pericardium. There can be collection of the fluid in these cavities. So in pleura, pleural effusion, what happens? The systemic symptoms are there. Systemic symptoms like low-grade fever and all. In addition, what are specific symptoms of pleural effusion? Patient may complain of pleuritic chest pain. There is a pain on one side. If he lies on that side, the pain becomes less. But if he lies on the other side, the pain is more. With the respiratory movement, there is a friction of the pleura and therefore patient gets pain. He also complains of breathlessness. On examination, we may be able to hear a pleural drum. Now, when there is a collection of fluid in the pleural space, the intrapleural pressure increases. The lung underneath that has collapsed. So the movements of that part, respiratory movements, are diminished. There is a dull note, breath sounds are absent, and X-ray chest will confirm the diagnosis, at least suggest the diagnosis. There is a blunting or obliteration of costophrenic angle. If we do USG, we will find out that there is a fluid collection above the diaphragm. So it is pleural effusion. Diagnosis is by fluid examination. In ascites, it is a TB peritonitis. Patient complains of gradual distension of abdomen. First, the fluid collects in the paracolic gutters, and therefore there is a shifting dullness. If you shift the patient on one side, the fluid will go to that side. That side will become dull, and this side, which is on top, will become resonant. So that is called as a shifting dullness. There may be fluid till we do sonography, and if it is tuberculous ascites, in sonography, naturally we'll see all the fluid, but classically it will also show fibrotic strands. Pericardial effusion, progressive breathlessness, chest pain. This effusion is encasing the heart, and therefore the feeling of the heart is affected. There are engorged neck veins, there is edema feet, we do X-ray and 2D echo. And all these fluids have to be removed. Now you see here, this is the liver, and just above the liver here you see that this is a collection of fluid, and this is a loculated empyema. Again, you see it on the ultrasound examination. See this liver, this is the diaphragm. So liver is just below the diaphragm, and above the diaphragm there is a fluid collection. Then we do paracentesis. We remove the fluid for examination. Most of this fluid is straw colored. We send it for chemistry. In this, if it is tuberculous, then it is exudate. And what are the characteristics of exudate? Proteins more than 2.5 grams. Sugar may be normal. Cytology, the cell count is much high in hundreds, and they are predominantly lymphocytes. So this is an exudate. Okay. In addition, the lymph node aspirate, the biopsied tissue, and this fluid we should subject to gene expert. Within 2 hours, we get the confirmation that this is MTB and this is rifampicin sensitive or rifampicin resistant. Coming to the gastrointestinal tuberculosis, if it is GI tract, there may be alternating diarrhea and constipation. Other systemic symptoms are there, low-grade fever, weight loss and all. But having diarrhea and constipation alternating, there may be lump in the right iliac fossa, because this is because of the ileocecal tuberculosis. Tuberculosis may cause intestinal obstruction because TB also causes intestinal strictures. And therefore, the investigation is CT abdomen and colonoscopy. When we do colonoscopy, a biopsy. Renal tuberculosis, when do you suspect? Painless hematuria. If there is a stone or if there is any stricture, the hematuria will be painful. But if you get painless hematuria, suspect tuberculosis. Now, patient's urine is showing a large number of pus cells. So you send it for culture sensitivity. And in 3 days, the culture does not show growth of any bacilli. And therefore, we call it a sterile pyuria. That means there are pus cells, but they are not growing any bacilli. So sterile pyuria is a very characteristic of renal tuberculosis. Do the pylography, and here the gene expert doesn't work. So we send urine culture sensitivity for acid-fast bacilli, but meanwhile, start at least the first line treatment. CNS TB, it affects most of the structures in the CNS. It can cause TB meningitis. It can cause tuberculomas in the brain, which will act as a space occupying lesion. It can affect the spine. TB spine can cause collapse and paraplegia. TB arachnoiditis. The patient will have fever, headache, vomiting, and he will develop neurodeficit or can develop convulsions. How to diagnose? CSF examination, CT, and MRI. If it is tuberculous meningitis, the CSF pressure will be raised, and again the proteins will be high, the cell count will be high, and the cells will be lymphocytes. Again, this can be subjected to gene expert. Next is joints. The joint tuberculosis affects the big joints. Monoarticular. It doesn't cause like rheumatoid arthritis, multiple small joints of the hands and all. It is monoarticular. So it affects big joints. All of you have heard tuberculosis of the hip, tuberculosis of the knee joint, and tuberculosis of sacroiliac joint. There is an effusion and patient will have difficulty in movements. So in that case, we do the X-ray, we do the CT scan, and also a good orthopedic surgeon can aspirate the synovial fluid, which is sent for the same examination, chemistry and cytology. Also, we can subject this to gene expert. And now genital TB. I talked about renal or urinary TB. Genital TB in females causes infertility. Now let me divert for a minute and tell you that we all have been exposed to tuberculosis in our childhood. When we have not developed, I mean, with the BCG, we should develop the hypersensitivity reaction. Suppose if we have not developed or we are exposed to TB before that, then these TB bacilli disseminate all over in the body. And wherever, to whichever organ they go, they form a small tubercle and remain there in a dormant state over years. And when there is an opportunistic, or when there is an opportunity that your immunity has gone down, these tuberculous bacilli, which are dormant, will get reactivated and cause tuberculosis. In females particularly, they have got this TB infection much earlier in the life. It has caused inflammation of the tubes, which has remained undisclosed. And finally, this tube is blocked because of fibrosis, which manifests in the later life as infertility. Okay, so when there is an infertility, you do all the investigation as histosalpingography and all that. In addition, we can do a laparoscopy, and laparoscopy will show you presence of tubercles on the uterus, presence of tubercles on the peritoneum. You literally see good tubercles. Okay, so that our diagnosis, at least provisional diagnosis, is confirmed. We can take a biopsy and study it. So genital tuberculosis usually appears much later in the life with the presentation as infertility. In males, the commonest affectation is epididymitis. Systemic symptoms are all there, In addition, the patient will complain of pain and swelling above the testes. There is a tenderness of the epididymis, and the commonest cause in our country is tuberculous epididymitis. Same thing can happen with the testes, and that is tuberculous orchitis. And both these can finally lead to infertility. So the cause of infertility, male infertility, in addition to all that semen examination, blah, 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 then we also take the history of mumps. But even if we take the history of TB, there may not be history of TB in the earlier life because it didn't manifest. And it has now manifested as infertility. So one of the investigations in these patients will be for tuberculosis. And these are some slides I'm just showing you out of interest. This is from HIV patients. Now these HIV patients, nowadays with the ART, they are in a good shape. Their longevity has increased, their CD4 count has increased. But before HIV, before ART, these patients were immune deficient. And they were complaining of loose motions, diarrhea, frequent diarrhea, and weight loss. I specially requested British Candy to carry out special investigation, special stain for stool to detect acid fast bacilli. And can you see, this is a stool examination which showed acid fast bacilli. That means body was so deficient that body could not form the granuloma, but the acid fast bacilli are excreted in the stools. Then we did some cases of colonoscopy and took a biopsy. And just see here, under the mucosa, there is a collection of acid fast bacilli. Okay, that's why I said HIV and TB go hand in hand, and that is one of the reasons our TB numbers are increasing. And this is what our study had shown, that because of the HIV, the patient is immune deficient, and therefore he will develop tuberculosis. In the early stages, the tuberculosis, in America, they started with HIV and said this is multi-drug resistant TB. But in India, when we studied, when they are immune competent in the early stages, their TB manifestations were like non-HIV. Upper lobe infiltration, cavitation, because the body was reacting. And therefore, we called that as HIV associated TB. We treated it for 6 months, responded very well. Patient continued. There was no ART at that time. After 2 to 3 years, again patient will develop tuberculosis because now his CD4 count has further gone down. So this will be now because of immune deficiency. It is HIV related TB and it will be disseminated. And lastly, our autopsy studies have shown what is called as AIDS with mycobacteriosis. Now this is a slice of kidney. Okay. And when Dr. Vagolikar, our HOD pathology, did the autopsies of this HIV patient, in those days, nobody was ready to touch the patient. Nothing was seen on gross examination. No tubercles were seen. But the histopathology, as you can see here, I hope you appreciate that the kidney is full of acid fast bacilli. This we called as mycobacteriosis. This again, brain, which is showing multiple acid fast bacilli, mycobacteriosis. And this is the same picture that we get even in African countries or underdeveloped countries. Okay, so TB is still #1 disease. Now, because we have decided to eliminate it in another 2 years' time, the National Tuberculosis Program, as I just now said, has started giving treatment free of cost to the households of a tuberculosis patient. So if you have any, if you suspect any, if you have a index case of tuberculosis in any family, please send the household contacts to the TB center for the treatment. It is Isonex, or they give two drug combination. Isonex given for 6 months. Other drugs are given for 2 to 3 months. Okay, so this is what we have started. Now it sounds very easy to make a diagnosis of TB. All these tests are available to us. We have clinical examination. We have all pathological tests. We have imaging, isn't it? Bacterial test, other tests, and imaging of all sorts. And still we have many challenges. I had presented this in one of our conferences as TB mimics. There are many conditions which mimic the tuberculosis. And I'll just show you one. This 30-year-old man, feeling generally unwell, blood test showed him hypercalcemic. So you got the clue, hypercalcemic. And what do you see on this X-ray? A big lymph node here and a big lymph node there. So bilateral hilar lymph nodes with hypercalcemia, your diagnosis is sarcoidosis. Okay, and that's why I'm still emphasizing that please do the bacteriological examination to confirm your diagnosis. Look for drug sensitivity and accordingly treat the patient. I think I forgot to tell you about one more test. Just 1 minute, bear with me. I talked about CBNAT, cartridge-based nucleic acid amplification test, or in other words, gene expert, which detects only rifampicin sensitivity. So then we have also called as another test, line probe assay. And this line probe assay takes 4 days to report, but it reports the resistance to other drugs like Isonex and rifampicin. That becomes multi-drug resistant TB. And then when we do the culture and develop tuberculosis, and when we grow the tuberculous organism, we carry out the drug sensitivity for all other drugs. So we know exactly to which drugs this MTB is sensitive. If it is resistant, then for second line also we carry out the sensitivity test, and accordingly the patient is treated. So I think that's all that I wanted to share with you. I hope I was clear enough, and if you have any questions, please send them on WhatsApp. I'll try to answer them. Thank you.